Hello and welcome to this video. It is a segment of Module 207, the Dual Diagnosis module, and this particular video focuses on the implications of being diagnosed with a mental illness or a dual diagnosis. This module has already covered common mental illnesses, common mental illness symptoms, what the DSM is and how it works, and how the world has defined mental illness, both in the past and how they define it now. We've also taken a look at two different definitions of dual diagnosis and described which one is the more current and the one we should use. Please make sure that you're comfortable in all of that material before you proceed with your project. That material is a prerequisite to what we're going to cover today. We will begin by reviewing the correct community living definition of dual diagnosis so that you know exactly what we're talking about. We'll also take a look at the implications of being diagnosed with a mental illness, and then the implications of being diagnosed with two things at the same time. We'll talk about how to use this knowledge in your project and additional sources you might use to supplement your knowledge. We'll also talk about considerations for stigma and how it affects people who are diagnosed with a mental illness, intellectual disability, or both. So to this point, we have talked about dual diagnosis and acknowledge the fact that there are people who use that terminology to mean something different than we will use it in the course and in our careers. The other way that it's used, I will mention briefly in a moment, the other way that it's used is no longer considered to be very current. And there is a growing and evolving acceptance that the term dual diagnosis means what we mean in the community living sector. So this is the definition we will use, and if you do more research and you come across any evidence that others are using a different definition, you should avoid those sources. For us, then, a dual diagnosis is the presence of both a mental illness and a cognitive or intellectual disability. Intellectual disability simply means that a person has a lower adaptive intelligence. They have pervasive effects because of that, and usually it shows up as an IQ that is measured below the score of 70. Some of the common mental illnesses that you might come across include obsessive compulsive disorder, post-traumatic stress disorder, schizophrenia, bipolar disorder, major depressive disorder, Tourette syndrome, intermittent explosive disorder, and a variety of different anxiety disorders. But that's just a list of the most common. Really, any mental illness can be combined with an intellectual disability and satisfy what we mean by this term. That includes addiction and substance abuse issues. Now, that's an important thing to talk about because the other group of people who sometimes use this term are talking about the presence of a mental illness and an addiction issue. That is still a concern in our field, but that is now becoming known by another name, concurrent disorders. So if you hear people talking about concurrent disorders, they're typically talking about the use of a substance at the same time as a person has an underlying mental health condition. That's different than the definition we are using here. So please make sure you're clear. So what does it mean for a person if they're diagnosed with a mental illness? And this really refers to any mental illness. And we're not at this point talking about people with dual diagnosis. We're talking about anybody. Before I go through the list, it's good to say I think that we are getting better at this. We're getting better at being honest and open about what it means to have mental illness. And we're starting to realize that people can have mental illness in some very subtle ways. Most of what I'm about to describe in this list is made worse if a person's symptoms are worse. The more intrusive or invasive a person's symptoms are in their life, the more likely that the things in this list will affect them. First on the list is social alienation and isolation from loved ones, feelings of loneliness. This can be a product of stigma and fear, but it can also be a symptom directly of the mental illness. For example, when people are schizophrenic or when they have major depressive disorder, often one of the things they do is socially withdraw or have difficulty relating to others. People in the mentally ill community, if we can call it that, are some of the most poor people on average that you'll encounter. Being poor is a very common side effect of being mentally ill, and so is inadequate or unstable housing. Inadequate housing means housing where you might be safe or where you might have access to the sorts of services in the community that you need. It's also quite possible that people have reduced health care, and this is particularly common in the United States, where public health care is not readily available for people who do not have an employer. It's getting better there, but it's not the same as it is in Canada. And even here in Canada, there are many services that require people to have money in advance. Even if they're going to get reimbursed for their medications or their treatments, they often need to pay ahead of time. And there are costs in simple things like getting to somebody's office or having the technology to connect with somebody through teleconferencing or telephone, which are growing ways to serve people with mental illness. And that leads to the third thing. In many cases, there are simply inadequate mental health services. There aren't enough psychiatrists to serve our communities, particularly in small and medium-sized towns such as the one where we live. That often causes people to be on lengthy wait lists or to wait for a longer period of time between visits than they would like, or to have very short and abbreviated visits. They often have to go through a lot of bureaucracy, sometimes very perplexing and confusing bureaucracy, in order to get the appointments they need, filling in various forms and qualifying for various programs, and that can deter people. Because of these things, people with mental illnesses can sometimes be more vulnerable to criminal activity, and they may actually want to self-medicate. We'll talk more about how stigma affects that, but of course if a person has tried to get help and they haven't been able to get it from, somebody might call a qualified or approved medical person, then they may start to get help in ways that aren't approved, such as street drugs or the use of alcohol. People, because they are poor, often end up living in neighborhoods that have a higher crime rate as well. And if their symptoms are visible to others, then they may be easily targeted. When people become stressed, they often start to have an aggravation or increase in their symptoms. The name we give this is decompensation. When a person is decompensating, what we're really saying in a fancy way is that their symptoms are getting worse. The word decompensation perhaps describes things a bit better. Rather than saying that our symptoms are getting worse, what it's saying is that the things we normally do to cope aren't working as well as they usually would. Normally we are compensating for our challenges by doing more of something else, like for example making sure that we go to therapy or maintain a schedule or exercise. When people decompensate, it means not so much that they stop doing these things, but that they're not having the effect we would normally expect. People with mental illness often have a higher involvement with the legal system. Sometimes their behavior is erratic and poorly understood in the community, so people call the police, even though that individual might not actually be doing anything dangerous. They might just be behaving in a way that is strange or disruptive. And people sometimes have difficulty as a result of their mental health diagnosis understanding social rules or how to read the social fabric. So in some cases, people are more likely to encounter the criminal justice system without even knowing why. And it's not always because people behave in a way that is scary or criminal. It's sometimes just because people don't understand things like, for example, the importance of being quiet in public spaces, or how to wait in a line, which might be something you'd see from somebody on the autistic spectrum. Folks with mental illnesses are often more reliant on social systems, and this can create a lot of instability. All that has to happen is that somebody sitting in an office in a place like Victoria can suddenly make a decision, such as the requirement for somebody to go and get a particular form or to see their doctor twice a year instead of once a year. And that can suddenly have major ripple effects in whether or not people continue to qualify for the very supports upon which they rely. If yesterday the threshold for somebody to get help was a $30,000 income level, and tomorrow it goes up to $35,000, there's going to be a group of people who will suddenly no longer be able to access the social systems. Something as simple as the changing of office hours or a bus route can have major implications on people who rely on these systems. Medications themselves, while very helpful, often have side effects. They can cause people to gain weight or retain water. They can make people feel thirsty. They can make people start to use things like caffeine to offset symptoms. They can change your moods and sleep routines. And as a result, sometimes people end up having a benefit in one part of their lives and difficulty in others. For example, I know people who had major declines in their energy levels or self-esteem because they gained a lot of weight after taking medications. You could probably think of others just based on your own anecdotal experience or what you might have observed in practicum or from talking to friends and family. The implications of a dual diagnosis take things up another notch. So when a person has an intellectual disability in connection with a mental illness, things become even more difficult. People in that circumstance become even more likely that they will be put into a scenario where others are going to take care of them or control them, whether it's a jail, which means incarceration, or an institutional setting where there's more high level of security and supervision. And that's because there really isn't a large number of people out there who understand fundamentally how to help people with these two complicating sets of needs. And because of that, we often end up having to try and control people using medications that sedate people, or physical restraints or isolation, being locked in a room or locked on a property. People therefore end up losing privacy. You have more people in your lives trying to control you, more of a high ratio of staff support. I've literally worked with somebody who had full-time staff, not one, but two people in his home all times of the day. That's unheard of, except in cases where people have high concerns about mental illness. The opposite, though, might be even worse, and that is that some people just simply cannot find services that are appropriate for them. So, for example, I've seen people develop neurocognitive disorder in their 40s and 50s, usually people with Down syndrome. Neurocognitive disorder, of course, is another mental illness. But the world doesn't quite know what to do with people who aren't actually senior citizens and have dementia or neurocognitive disorder. So sometimes they put them in hospitals, or they have people move in with a bunch of people who are 30 years older than them and have nothing in common. So a lot of times people just simply don't have a proper service, or the service they have is a very significantly compromised one. As you can imagine, all of this can create even more stress. Imagine that you have something like an uncontrolled pain disorder or an illness that nobody can accurately diagnose. The longer that goes on, the more you would start to feel stressed and have less hope in your life. And that's what it's like for a lot of people who have both an intellectual disability and a mental illness. It's also important to realize that one of the fundamental things in psychosocial rehabilitation is to try and help the person at the center of the circle, the supported person, do as much for themselves as possible. Things like taking their own medicine, getting to their own doctor's appointments, and doing all the sorts of things that will keep them well. The best thing we can do is try to give the person control over that. But when we're talking about people with intellectual disabilities, that work becomes difficult because teaching and learning are affected by intellectual disability. That often means that people lack the self-care skills they have, and that can mean that they don't have as good wellness or comfort. So for example, if you can't verbally communicate that you're feeling anxiety, then you are not as likely to go and get a PRN medication that might have helped you feel better until your behavior is so obvious that others notice it. That would be a lot harder than being a person who could go to the cupboard and get it for yourself. This means that people are much less likely to have their symptoms controlled. Without being able to get information from the supported person about what they're experiencing, it's very difficult to tell what's working and what's not working. It's also even more difficult than it is for a person with mental illness to find this person informal social supports. That feeling of loneliness and alienation tends to really worsen the psychological effects of a mental illness. People encounter fear and stereotyping, and they're less likely to work and more likely to be poor. As a result, many people cope through self-medication. They use substances, or they become involved with the justice system. And they end up having less involvement in their own planning. So as time passes, normally a person with mental illness would gradually get more and more control over their own symptoms and their own health care. That's much more difficult to do when a person has an intellectual disability. All of this can be summed up in a really simple way. Whatever the implications are of a mental illness, they are probably twice as high for a person who has an intellectual disability as well. And one of the challenges is, how do we actually diagnose and treat a person with developmental disabilities? And this particular slide will be incredibly important for you as you do your project. One of the challenges is how hard it can be to determine whether what we're looking at are symptoms of a developmental issue, a psychiatric issue, or a behavioral or motivational issue. For example, if a person is hitting himself in the head and he's nonverbal, is it because the person has headaches? Is it because they are experiencing some kind of psychiatric symptoms, such as hallucinations? Or is it because the person's developmental abilities are affecting their ability to communicate? And this is how they're doing that. It can be very difficult to tell. The client may have very limited ability to tell you what's going on inside of their head or inside their body. And it's too often the case that we don't have good records or the ability to reach out to people who've known that person for a long time. So the history of that person may be very inadequate. Some of the things that we do to support people who have a diagnosis of mental illness don't work for people that have particularly high-level intellectual disabilities. So, for example, talk therapies are often not as effective for people because there's a high degree of self-insight and a high degree of communication needed for them to work. Self-help techniques like working through workbooks or going through a video-based program, again, take a degree of intellectual ability. And the ability to take your own medication, as we've mentioned earlier, can be really difficult for a person if their intellectual level is not that high. The person may also find it very confusing to understand what's the difference between, for example, their day program worker or a person in their group home and a person that is a counselor or a psychiatrist. I've seen this firsthand. I took a person to see a counselor and they couldn't understand that they were supposed to start talking about their problems with that counselor. The counselor, after 2 or 3 visits, simply said, "I don't think this is going to work. The person doesn't know what I do. They don't understand that they're supposed to come here and talk about things, and we're just wasting your time." And so that was a real big learning moment for me. But where do you go? And unfortunately, there's still not very many places out there that provide appropriate services, because not very many people have gone and explored this fairly narrow part of the field. There are lots of people with intellectual disabilities, lots of people with mental illness, but until recently, there hasn't been as much acknowledgement that there's a fairly significant group of people who have both of those sets of needs. And as a result, services and expertise just don't exist to the level we need. How can you use this knowledge? Well, I hope you took notes or can go back and look at your slides and take what you've learned here and apply it once you understand the diagnostic criteria for whatever disorder you've chosen to study. In order to understand that diagnosis, you should take a look at a few things and then see how they might be affected by what we've just discussed. For example, you might look at the incidence. If something's a rare disorder, the chance that it might show up in the population of people with intellectual disabilities is probably not high. Look at the symptoms and see whether or not they would particularly be challenging to see or to understand unless you could talk to a person. Think about whether or not the treatments that are known for that particular disorder tend to be in the category of things that don't work as well for people with intellectual abilities, things like group therapy, self-help, and talk therapy, or whether the sorts of things that can work well, such as medications. So I want you to really know your diagnosis beforehand and then think about what we've just learned. Does your diagnosis particularly sort of push on some of the implications we've talked about? If you're interested in digging deeper, you can find out more information in the DMID, the Diagnostic Manual of Intellectual Disability. We have a copy of that in our classroom. You can also look up the Habilitative Mental Health Care Newsletter. This is a journal, and unless you have access to it, it will probably not be something that you can download easily, but you may be able to find information through Google Scholar about this or other journals. And a good source is the Canadian Association for Mental Health, or CAMH, website. Notice this is not CMHA. Don't make that mistake. I've looked at both, and the CMHA definition is not as clear as the CAMH definition. I'm a big fan of the latter. And we've covered a lot of this already, but I do want to talk a little bit about how stigma in particular affects people. And again, emphasize that everything we're talking about is aggravated further when we talk about people with mental illness and intellectual disability. So stigma, again, is simply a negative prejudgment or a stereotype. And stereotyping isn't always bad. For example, if you told me I should watch out for bears, I probably would assume that you meant all bears. It wouldn't be a bad thing, and it can be a constructive way of helping me be cautious. But sometimes we're too quick to prejudge or reluctant to go back and question our prejudgments, and that can create a barrier. And that's particularly true for people with mental illness. It's highly affected by stigma. And intellectual disability is also highly affected by stigma. It's still quite common in our community for people to make fun of people based on their intellectual ability. Now imagine you put the two types of stigma together, and the effect, as you might imagine, is pretty multiplied. As a result of stigma, many people avoid telling others what they're experiencing, and that has the effect of slowing down or even stopping them from getting help. Patients are often reluctant, once they do get offered help, to take it because the help itself is stigmatized. For example, people might be willing to take a medicine if you told them it was for a flu or an ear infection. But as soon as you tell them that their medications are associated with something like their moods or their thoughts, people often perceive them as far less likely something they're far less likely to want to take. And that's true of other forms of treatment too, such as counseling or group therapy. We have a sense in our community that these are things that are associated with weakness or being strange, weird, or unrelatable. Family and friends sometimes, and in particular we see this in some parts of our community based on socioeconomic status, educational status, culture. All of these things can make this particular thing even harder. In some cases, family and friends sometimes alienate people when they find out that they have a mental illness. And of course that makes things worse, because when we feel bad about ourselves or feel lonesome or have a sense that we're no longer welcomed into our community, anything we might do to help make ourselves feel better or be better seems like a tougher mountain to climb. So it really aggravates whatever symptoms people have. Employers and landlords are often reluctant to help people who have mental illness, and that can make things worse as well, because housing instability and poverty are incredibly stressful and make any attempt to address the person's underlying mental health issue really less likely to bear fruit. And community stigma sometimes makes it even difficult for a person to find the services they need. We tend to have a lot of fear, and we find out that somebody wants to put a mental health facility in our community. You often start to see protests. Those protests can have the effect of having those facilities located far away from population centers, making it difficult for people to access them. And in some cases, they just plain and simple don't get built because politicians and community leaders can detect that it's not a popular idea to spend tax dollars or to build these facilities. And so we're really under-resourced. And that's true of any type of mental health symptom service, and it's even more true, as I've said, when it comes to dual diagnosis. Hopefully this has been helpful to you, and I would like to see you try applying what you've learned here to your understanding of the diagnosis you're studying. Don't forget that once you do that, you're welcome to run your draft past me and see whether or not you're on target. Good luck.